Good morning, everyone. My name is Dr. Bing Han. I'm a board-certified dermatopathologist currently practicing in Georgia. For the first-year residents, welcome to LSU. I know this is an exciting and maybe slightly overwhelming time, but I guarantee you that you are in great hands here. It's truly a pleasure and honor to be a volunteer lecturer for me for your dermatopathology series. I'm so grateful to Dr. Bala and the other LSU faculty members for this opportunity to be a part of your education. Over the next few sessions, we will go through key dermatopathology concepts, pattern-based approaches, and real-world diagnostic tips that I hope will be practical and helpful both on your board's exam and in your practice as well. So let's get started. Today, initially, I hope I could give you a live interactive lecture. However, because of some family emergency, I had to pre-record this lecture and give this recording. I hope for the next session we will be able to have a real lecture so that we can do live interactions. Thank you for your understanding. As you can see from this outline, this lecture was originally scheduled for May, but due to some scheduling changes, we've moved it to now in July. So we are not starting at the most conventional point in this series, such as the benign neoplasms, including SKs and malignant neoplasms, such as basal squamous cell carcinomas, etc. And I will admit that these congenital and bullous disorders may not be the most high-yield topics in your daily Dermpath sign out right now, but I can promise you this: we are going to use this opportunity to go back to basics, the foundational histology as well as the physiology of the skin structure. That understanding is critical, and once you build it, it will help you for everything else fall into this place more logically, especially when we tackle complex inflammatory or neoplastic disease later on. So today we will cover some base histology and work our way through key blistering diseases and congenital disorders, with an emphasis on pattern recognition, clinical relevance, and common board pros. So before we dive in, I want to show this single slide to help us orient ourselves where we are in the big picture of inflammatory dermatosis. As many of you may recall, last year's dermatopathology lecture series, we covered the non-bullous inflammatory patterns, everything from spongiotic to interface to thoraciciform patterns to superficial and deep perivascular infiltrates, nodular and diffuse patterns, and so on. So today we are going to complete this series by focusing on the bullous disorders, both intraepidermal and subepidermal patterns. So this is the final piece of the inflammatory dermatosis puzzle. And while blistering disorder are not something you sign out every day, understanding the histological split and correlating it with the clinical presentation can really sharpen your diagnostic confidence. So let's talk about the normal skin histology. This is a skin probably from the person's trunk, and we can see there is outer layer, which is the epidermis, and below the epidermis is the dermis, and below the dermis is a subcutaneous tissue or some adipose tissue, fatty tissue, etc. Within the dermis, we can see some other skin adnexal structures as shown here, which is the eccrine sweat glands. Also, based on different locations, we may have abundant hair follicles, or we can have apocrine sweat glands if this is in the groin area or in the axillary areas as well. There are different types of skin in different anatomical locations of the body, And I want you to be able to recognize two types of skin. And this is the first one. And I hope you can tell this is probably from the person's head or somewhere close to the scalp area. Or if this is a male patient, this may be the area from the cheek with lots of beard. The reason is we can see abundant sebaceous glands, and the sebaceous unit is very prominent in this section. Also, we can see abundant hair follicles, and some of the hair follicles are extending super deep into the subcutaneous fat. Those are all the features of the skin in the scalp area, or at least on the head. And in contrast, this is the skin from the acral area. And why is that? The reason is if you look at the epidermis, the stratum corneum is super thick. So this is the number one feature of the acral skin. And the number two is below the stratum corneum, there is a layer look translucent. This is the layer we call stratum lucidum, and this layer only exists in the acral skin, such as on the palm, on the sole, or fingers or toes. Otherwise, there is no hair. So this is a non-hair bearing skin with very thick stratum corneum and stratum lucidum. Those are the features of acral skin. And let's talk about those layers in details. We have talked about the stratum corneum. In non-acral skin, the stratum corneum usually looks very basket wave or loose. And below that, there shouldn't be any stratum lucidum on the non-acral skin. And below that is the stratum granulosum, means those are still keratinocytes. There are still preserved nuclei, but there are abundant granules inside of the skin, inside of the cells. Below that is the stratum spinosum, means those keratinocytes, they have the shape of a polygonal shape. And even below that is the stratum basal. So this is the area, usually we can call them basal there, basal cells. And those basal cells are the stem cell in the epidermis. They start to replicate, they start to divide and get mature. Those cells being pushed upward and start to lose their nuclear structures and fall off when they reach the stratum corneum. So this is the normal skin histology. And below that, we can see there are abundant dermal papilla. The dermal papilla is the area to have abundant blood vessels or capillary vessels. And the blood flow went into these papillary vessels to provide the nutrition and provide the oxygen to give the support to the epidermis. So the dermal papilla is also a very important structure. To help visualize the structure of the skin, let's think of the epidermis as a building sitting on a foundation. And the foundation is the dermis, while the building is the epidermis. Where the building and the ground meet is the interface, and we call the interface as the dermo-epidermal junction. Now, just like a building is made of bricks, the epidermis is made of keratinocytes. They put on top of each other in layers. That will keep those bricks tightly connected to each other. And we have desmosomes. Those are like the cement or the bolts that hold the brick to brick. But a building is also need to stay attached to the ground, right? So that's where the hemidesmosomes come in. They act like anchors that fix the bottom layer of the epidermis to the basement membrane and the dermis underneath. Without them, the whole building could lift off from the ground, which as well we see is exactly what happened to certain bullous diseases if there are involvement by the hemidesmosome or the desmosome. The picture on the left is a diagram zoom in on the structural components that holds the epidermis together, specifically the desmosomes as well as the hemidesmosomes. So let's start with the desmosome, which is highlighted on the right. Desmosomes are like intracellular connections. They tightly link adjacent keratinocytes together, giving the epidermis its mechanical strength. Imagine it like the steel bolt holding together these bricks in our epidermal building. This spans the extracellular space and bind the keratinocyte to each other. Inside of the keratinocytes, this connect to placoglobin, desmoplakin, and placophilin, which in turn anchor to the intermediate filaments of the cytoskeleton, providing the keratinocytes intracellular stability. And from a clinical perspective, this is essential in understanding diseases such as bullous pemphigus vulgaris, where the autoantibody will attack the desmoglein, which usually is the desmoglein 3, leading to loss of cohesion between the keratinocytes, a process called acantholysis. And we will contrast that with the hemidesmosomes in the next slide, which anchor the basal keratinocytes to the basement membrane. And this is the hemidesmosome. While the desmosome connect keratinocytes to each other, the hemidesmosomes are the anchoring structure that connects the basal keratinocytes to the basement membrane, as shown here. So the entire epidermal building stays attached to the dermis. On the right, we zoom into the hemidesmosome structure inside of the cells. The keratin intermediate filaments, which typically are number 5 and number 14, connect to the proteins such as BP230 as well as BP180. And those proteins will anchor to the transmembrane components, such as the collagen 17 and alpha 6 beta 4 integrin, which then bind to laminin 332 and lamina lucida and lamina densa layers of the basement membrane. And finally, those anchoring filaments will secure the entire complex of the underlying dermis. Those are the structures of a hemidesmosome. From a clinical standpoint, this is critical for understanding the subepidermal blistering disease. For example, in the bullous pemphigoid, the antibody may target either BP230 or BP180, leading to detachment of the dermoepidermal junction. And in another disorder called epidermal lysis bullosa acquisita, or EBA for short, the target is the type 7 collagen, disrupting the anchoring fibrils deeper down the basement membrane. So again, the hemidesmosomes are like the anchors of the foundation bolts that keep the epidermis intact to the dermis. And when they are damaged, the building lifts off and forming a subepidermal blister. Now that we understand there are two major ultrastructural levels where the blisters can occur, including intraepidermal, which is shown here, the blister is inside the epidermis, versus subepidermal, where the blister is beneath the epidermis. Now we can start to map the specific disorders to each category. Under the intraepidermal blister category, they include the classic examples of pemphigus vulgaris, pemphigus foliaceus, and paraneoplastic pemphigus. Those disorders, they occur when the cohesion or the desmosome between the keratinocytes are disrupted. In contrast, the right category, which is the subepidermal blister, result from defects at the dermal-epidermal junction, often involving the hemidesmosome or the basement membrane zone proteins. This includes the conditions such as bullous pemphigoid, dermatitis herpetiformis, linear IgA bullous dermatosis, epidermolysis bullosa acquisita, porphyria cutanea tarda, and paraneoplastic pemphigus. You probably have noticed that the paraneoplastic pemphigus is listed in both categories. That is because it is a complex entity with overlapping features both intraepidermal acantholysis as well as interface or subepidermal involvement. That is why you see the PNP listed both. So let's go through this one by one. Let's start with the pemphigus vulgaris, PV. Let's start with the pemphigus vulgaris. This is kind of a classic example of an intraepidermal blistering disease. Classically, you will see those flaccid bullae on the patient's body. These are usually fragile blisters that break open easily. So most patients, they don't even show intact blisters. Instead, they show up with raw erosions or shallow ulcerations. One key physical exam finding is the positive Nikolsky sign, which means if you apply gentle pressure to the skin, the epidermis just sloughs off. And don't forget about the mucosa. This disorder almost always involves the mouth, and sometimes that's the only place you will see it, presenting as painful erosions. And it tends to affect middle age to older adults, usually in their 50s or 60s. And like many other autoimmune disorders, it can be associated with other autoimmune conditions such as MG or thymoma. The underlying issue is the autoantibody against desmoglein 3, or we use abbreviation DSG3, which is the key protein in the desmosomes. Those breaks and cement connection between the keratinocytes. Some patients also make autoantibody not only to DSG3 but also DSG1 as well, which adds more superficial skin involvement. So when there are autoantibodies bound, the desmosome fall apart and the keratinocytes lose connection. So that's what we call acantholysis, and you can see here. The keratinocyte cannot hold each other. They start to acantholyze. Histologically, this split happens right above the basal layer, but do not confuse with subepidermal separation. This is still inside of the epidermis, so this is still an intraepidermal separation just above the basal layer. And those basal cells stay stuck to the basement membrane zone pretty well, giving you the classic appearance of a row of tombstone, like here. And you will also often see eosinophils floating in the blister. So one interesting finding is that people call that tombstone sign also because before the era of using steroid, the mortality rate is so high, it can be as high as 90%. So 10 pemphigus vulgaris patient will have 9 deaths. So that is a very critical disorder before the usage of steroid. That's why when people see that morphology, people call that tombstone sign. So overall, there are several key points I want you to remember. Mucosal erosions, flaccid blisters, intraepidermal split, and tombstone. So that's the pemphigus vulgaris. And also because the separation is so high, it's inside of the epidermis. That's the reason we have the flaccid and fragile blister. That is the reason. So let's talk briefly about direct immunofluorescence, or DIF for short. This is a technique that detects in situ antibody or complement deposition in the skin. For example, let's imagine you are biopsying a patient and cut a frozen section put on this glass slide. And then you use the primary antibody, which probably you can imagine as an IgG, anti-IgG. That is bound to the autoantibody on the surface of the skin. And then you use a second antibody with the fluorophore to bound the primary antibody. Then you can examine the color under the fluorescent microscope. A few key questions to ask you is after performing this exam is what is the shape of the staining? Is that a granular staining or is that a linear staining? The second question to ask you is what are the immunoreactants? Do you see IgG or IgA or C3? Answering those questions or the combinations will help you figure out the disorder and the level of involvement. So let's take a look at the pemphigus vulgaris. This direct immunofluorescence will show a classic intracellular IgG and C3 pattern, but usually the IgG is usually stronger than the C3. This pattern looks like a net, so we call this net-like pattern or fishnet-like pattern, or some people use imagination called chicken wire pattern. And that makes sense. Remember, the antibodies are attacking the desmogleins between the keratinocyte, which the staining is concentrated within the epidermis, outlining each keratinocyte. This is a really helpful confirmatory test, especially you don't know where is the separation. And one thing I forgot to mention is that this biopsy usually is a biopsy from the normal appearing skin adjacent to the blister. So you will see the antibody, and if you're lucky enough, you can even see there is a separation under this direct immunofluorescence image. Next up is pemphigus foliaceus, which you can think of as a more superficial cousin of pemphigus vulgaris. This disorder affects the upper layer of the epidermis, so the blisters are really fragile. They tend to rupture quickly and leave behind just crust erosions. That is often what you see clinically. You will also get a positive Nikolsky sign since the keratinocytes in the upper epidermis are loosely connected and shear off with pressure. The distribution is important. It typically shows up in a seborrheic pattern, meaning areas like scalp, face, upper chest, and back are usually involved areas. One big clue is that it does not involve the mucosa, which helps you distinguish it from the pemphigus vulgaris. Those patients usually have scaly red patches, such as here. It can look like seborrheic dermatitis or even eczema, which is why it can be misdiagnosed early. So itching is also very common too, although not always the main complaint. The crusted and the erosions tend to be more bothersome for the patient. So if you see the superficial erosion with scale in seborrheic areas and no mucosal involvement, you should think about pemphigus foliaceus. But you may want to ask, both pemphigus foliaceus and pemphigus vulgaris, they are affecting the epidermis. Why the pemphigus vulgaris has shallow erosions instead? In contrast, the pemphigus foliaceus only left over those crusted erosions, but not big erosions. Let me tell you why. So histologically, you will see the acantholysis up is so high. Basically, the keratinocytes in the granular layer start to fall apart. And the direct immunofluorescence also show the same net-like intracellular IgG pattern we saw in the pemphigus vulgaris, but this time the concentration of the IgG is more superficial. So when the separation is only on the top, you don't have the shallow ulceration or erosions as the pemphigus foliaceus. And let's talk about the physiology. In pemphigus foliaceus, the autoantibodies are directed against desmoglein 1, which is located in the upper layers of the epidermis, near the granular layer. That is why the blisters are forming superficially blister, just beneath the stratum corneum, and we call that subcorneal split. You can also see some eosinophils in the blister cavity as well, although the infiltrate is more mild. A really important differential diagnosis is the streptococcal scaled skin syndrome, or people call that SSSS or 4S. Those two disorders both can show subcorneal blister and erosions, but the 4S syndrome is toxin-mediated, not immune-mediated. Those streptococcal are generating those toxin and causing this separation. So you will not see acantholysis, and you will not get a positive direct immunofluorescence finding in the 4S. Another clue is the inflammation. We talked about the pemphigus foliaceus. The inflammation tends to have more eosinophils and lymphocytes, while the 4S, since it's a bacterial infection, almost always has no eosinophils or lymphocytes. You may see some neutrophils, but it is caused by toxin, not by bacteria itself. That's why you don't see many inflammatory cell in the 4S. That is a key finding. Another good thing to know is that the pemphigus foliaceus generally has a better outcome than the pemphigus vulgaris, which has the tombstone sign. And usually the pemphigus foliaceus, especially with the early diagnosis and the treatment. So let's take a second and ask yourself, why do the pemphigus vulgaris and the pemphigus foliaceus behave so differently? Why does one affect mucosa and cause deep erosions, while the other is more superficial and spare mucosa completely, if they both involve the desmoglein? So it all comes down to which desmoglein is being targeted and where the desmoglein is expressed. So for the pemphigus vulgaris, the targeted antigen is mainly the DSG3, or a small percentage of the PV will have DSG1 involvement. In contrast, the pemphigus foliaceus, the main targeted antigen is DSG1. So why that makes a difference? Let's look at this picture. In the normal skin, the DSG3 is expressed mainly at the bottom of the epidermis, while the DSG1 is mainly expressed at the top. While in the mucosa or the mucous membrane, both DSG1 and the DSG3 are expressed more heavily at the top, while the DSG3 is more stronger than the DSG1. So that is the difference in expression. So with that in mind, in pemphigus vulgaris, the autoantibodies go after desmoglein 3, which is here, which is heavily expressed in the lower epidermis, and especially in the mucosal membrane. No matter the patient has only DSG3 antibody or both involvement of the DSG3 and the DSG1, there will be skin involvement as well as mucosal involvement, right? That is the pemphigus vulgaris. In contrast, in pemphigus foliaceus, the autoantibody will spare the DSG3, only target the DSG1. The DSG1 lives in the upper epidermis, so that is where the split happens. It is the subcorneal separation. But there is the key. The mucosal membrane has almost very minimal DSG1 with a super strong DSG3. If there is a diminished DSG1, there is still abundant DSG3 to compensate the mucosal membrane. That is the reason you'll see the mucosa stays intact, right? So let's summarize it again. For DSG3, it can compensate the DSG1 in the mucosa especially, but the DSG1 cannot compensate for DSG3. That is why pemphigus foliaceus spares the mucosal surface and stays superficial, while the pemphigus vulgaris can hit deep and affect the mucosa too. Right? Makes sense? And this is also a great example how antigen distribution directly explain both the clinical pattern and the histological of the split. Now you understand both disorders pretty well. And here is a quick side-by-side to wrap up the pemphigus vulgaris versus pemphigus foliaceus. The PV is caused by antibodies to desmoglein 3, or both DSG3 and DSG1. This split happens just above the basal layer, so that's why we see mucosal involvement. DSG is expressed in the mucosal surface. Clinically, you get flaccid blister, and on the direct immunofluorescence, you will see the classic fishnet pattern of intracellular IgG and C3. In contrast, the PF targets DSG1, which is located higher up in the epidermis. That gives you the subcorneal split and no mucosal involvement. Because the mucosa doesn't really express DSG1, right? Instead of intact blister, you usually see crusted erosions, and the direct immunofluorescence study is similar, still a fishnet but more superficial. So again, the antibody target explains the clinical and histological differences really nicely, right? If you remember, the paraneoplastic pemphigus was included in both intraepidermal and subepidermal separations, but for now we will skip it and we'll come back later. And we will talk about the disorders in subepidermal category. Now we are moving into the subepidermal blistering disorders. Let's start with the most common one, which is the bullous pemphigoid, or BP. Clinically, the early phase can look like urticaria, which presents as red, itchy patches without blisters. But later on, the patient will develop tense blister, such as these ones, often very itchy, especially in older adults. And you see this picture. There are very tense bullae in the background of erythematous skin. And it usually affects older adults. These bullae are very large and can be sturdy and rigid, not like the flaccid ones you will see in the pemphigus foliaceus or pemphigus vulgaris. And Nikolsky sign is negative. Remember, that one is positive, which makes sense since the epidermis is intact. Distribution-wise, it tends to affect the trunk and the flexor surface of the extremities, and the mucosal involvement is minimal or absent. Those are the key differences between the pemphigus and the bullous pemphigoid. This is the goid, not the gus, okay? So, pathophysiologically, this is a disorder affect the hemidesmosome. The autoantibody are direct against BP 180 or BP 230. Like many other things in pathology or dermatology, the BP 230 has another name called BPAG1, while the BP 180 has another name, BPAG2. But for now, you can just remember 230 and 180. So this leads to detachment of the epidermis from the basement membrane, causing a subepidermal blister. On histology, if you catch the lesion early, like we mentioned, if this is the urticarial phase or prodromal phase of the bullous pemphigoid, you might just see some eosinophilic spongiosis and some papillary dermal edema. That's just a urticarial phase. If without clinical information, you may call this urticaria. But when the lesion progresses, you will see there is a subepidermal blister, often filled with eosinophils and some neutrophils. And finally, when we perform the direct immunofluorescence study, it has a classic finding. You will see the smooth, linear deposition of C3 and IgG along the basement membrane zone. And interestingly, the C3 is seen in nearly 100% of the cases, while the IgG is about 90% of the cases. So, lastly, as a summary, when you see a tense bulla in an older adult with eosinophils in the split and linear C3 at the basement membrane, you know that is a textbook bullous pemphigoid. Okay? So as promised, the paraneoplastic pemphigus, or PNP for short, is back. Let's talk about the paraneoplastic pemphigus. This disorder is rare, but it can be very severe. And this disorder is almost always associated with underlying malignancy. And the common malignancies include non-Hodgkin lymphomas, CLL, and Castleman disease, etc. What makes the PNP really challenging is that the presentation. Usually the presentation is polymorphic, and you can see the blisters, you can see erythematous macules, and sometimes you can see mucosal involvement, and usually the disorder or the blisterings can be extensive and very painful. So the pathology is very messy. That is because the autoantibodies in PNP target a wide range of antigens, not just desmoglein, not just BP180 or BP230 like the classic pemphigus or pemphigoid, but the PNP antigen will also include desmoplakin, BP antigens, and others. So both desmosomes as well as the hemidesmosomes will be involved. That is why the clinical and histological features overlap with the pemphigus vulgaris, bullous pemphigoid, and even the erythema multiforme. Histologically, this picture is just a complex. You might see acantholysis like PV here. You may see a subepidermal blister like BP here, and even lichenoid interface similar to erythema multiforme. The key is to recognize this weird overlap when nothing quite fits one category. When you perform the direct immunofluorescence study, the pattern can also reflect its complexity. You will often see both intracellular fishnet IgG and linear IgG or C3 at the basement membrane zone. When you see that combo, especially in a patient with known or suspected cancer, you have to think about the possibility of PNP. This disorder is not just a skin problem. It can be fatal, causing some fatal pulmonary complications. So if you suspect it, it's a dermatological emergency, and you should immediately investigate for underlying malignancy. Now let's go over dermatitis herpetiformis, which is a really classic example of an IgA-mediated subepidermal blistering disease. Clinically, the key features are itchy vesicles and papules that pop up in a symmetric distribution, especially on the extensor surfaces such as elbows, such as knees and buttocks. The lesions are so itchy and the patients often scratch them off. So what you see are more like crushed papules and excoriations rather than intact blisters. So why the name is so funny, has a herpes there? Is that a viral infection? Actually no. The name actually came from how it looked clinically and histologically, long before anyone understood the underlying autoimmune etiology. The rashes look like grouped vesicles, reminiscent of herpes viral infection. It wasn't until later that we found the true cause was IgA-mediated and linked to celiac disease, not HSV. But the name stuck, even though we know the mechanism is completely different. The disorder tends to affect younger adults, usually in their 30s or 40s, and there is a strong association with celiac disease and gluten sensitivity, especially in patients with Northern European family history. And the pathophysiology is driven by IgA antibodies, specifically against transglutaminase, especially the epidermal type. This antibody form immune complexes that deposit at the tip of the dermal papillae, which then recruit numerous neutrophils and cause inflammation and blister. On histology, you will see there is a subepidermal split, often with neutrophilic microabscesses in the dermal papillae, sometimes with a few eosinophils, but mainly neutrophils are the key. And when we do the direct immunofluorescence, you will get the hallmark finding, which is the granular IgA deposits in the dermal papillae. The C3 might be present, but the IgA is the star here, and the granular pattern helps distinguish this one from other IgA disorders such as linear IgA dermatosis. So, in summary, if you got itchy young individual with papules on their elbows or knees with subepidermal blister with neutrophils and granular IgA on direct immunofluorescence, you got the classic dermatitis herpesiformis. Now let's talk about the linear IgA bullous dermatosis, or LABD, which you can think of as the IgA counterpart of bullous pemphigoid, but with some unique features. Clinically, patients present with grouped vesicles and bullae, often forming annular or ring-like patterns, especially on the trunk or limbs. It's itchy and mucosal involvement is common, especially in adults. For the LABD, it has a bimodal distribution. It shows up in young kids, usually around 4 to 5 years old, and again in the older adults around 60 to 65. In adults, it's often drug-induced, with vancomycin being the most classic trigger, but penicillins and other medications can do it as well. Pathophysiologically, the autoantibodies are IgA, as the name implies, and they target the basement membrane zone, just like the bullous pemphigoid. Specifically, BP180 or L81. L81 is actually just a portion of BP180. So the pathophysiology is just like the BP, but the IgA replaced the IgG. So that will lead to subepidermal blister. On histology, it looks very similar to dermatitis herpetiformis. If you remember, that can have a dense microabscesses composed of neutrophils. So you will see this subepidermal blister with neutrophilic infiltrate, often clustered at the dermal papillae. But what sets the LABD apart from either BP or from the DH is the direct immunofluorescence study. It shows a linear IgA deposition along the basement membrane zone, rather than the granular IgA like DH or IgG-C3 like in BP. That is the key diagnostic feature. So if the DIF shows a linear IgA deposition, that is LABD, and check for recent medications, especially vancomycin. Next disorder is the epidermolysis bullosa acquisita, or EBA. It is a rare blistering disorder that usually affects older adults. The blisters are large, tense, and often form in trauma-prone area, like the elbows or the knees and the hands. Unlike other blistering disorders, this one may leave behind scars. You might see mucosal involvement, and clinically it is associated with systemic disorders such as inflammatory bowel disease, the IBD, or multiple myeloma MM. Pathophysiologically, the EBA is caused by autoantibodies targeting the type 7 collagen, which is the main component of the anchoring fibrils beneath the basement membrane. On histology, we typically see the subepidermal split with very little inflammation, usually just a few perivascular lymphocytes, so it's sometimes hard to distinguish from bullous pemphigoid on H&E. And here is the demonstration of the location of the collagen 7. And remember, the BP is targeting the BP 230 or BP 180. So the separation from the ultrastructural level, it is lower than BP. And if we do the direct immunofluorescence, it will show a linear deposition of IgG along the basement membrane zone, sometimes with C3 as well, but the IgG is more dominant. This pattern looks very similar to bullous pemphigoid, so clinical correlation and salt split test can help in differentiating these two. So the question is, what is salt split? Now let's talk about this very useful technique called salt split test. It can help us to differentiate EBA from the BP. So how do we do it? The technique is we incubate either the normal human skin or the patient's skin in 1 molar saline for about 48 to 72 hours. That salt split technique will create an artificial split at the basement membrane zone, and more specifically at the area of lamina lucida. So this arrow demonstrates the location of lamina lucida. And if you pay attention to the location, this is the top part. The BPAG, BP230, is located above this separation, while the type 7 collagen is below the separation. After that, when we do the direct immunofluorescence study on this salt split skin, you will see the autoantibodies bounded in somewhere. If the autoantibody bind to the roof of the split, which is in this location, that support a bullous pemphigoid. If they bound to the floor, which is here, that will support the diagnosis of EBA. So in short, the BP binds to the roof while the EBA binds to the floor. I hope that makes sense. But if you still don't remember, this is the easy and dirty way to help you. So we understand the roof is BP, floor is EBA. So I just use this picture resemble the movie in the movie Up, and you can see for this floor, the balloon is connected to the roof. So BP equals balloon equals roof. In contrast, the EBA, which is the floor, is connected to the earth. So EBA equals earth equals floor. That is how I remembered. I hope that works for you as well. Now let's move on to the next important category called Porphyria cutanea tarda, and for short we use PCT. Clinically, it presents with bullae and vesicles, especially in sun-exposed areas, such as back of the hands and forearms. Mucosal involvement is rare, and it typically affects adults, and you might hear patients also mention increased photosensitivity or even dark-colored urine. What is the pathophysiology? It is due to reduced activity of the enzyme uroporphyrinogen decarboxylase, or it's easier if you just call UROD. This will lead to a buildup of porphyrins in the skin, which are photosensitizing. Under the light exposure, that buildup causes damage and blister formation. On histology, you will see a subepidermal blister, usually with very little inflammation. One classic clue is the appearance of festooning. So here is the festooning. The dermal papillae look rigid and sort of hanging into the blister cavity. You see here. And another feature is you may see those dense collagen around the blood vessel. If you do the direct immunofluorescence study, you might see some linear IgG, more than IgM, along the basement membrane. And also, there are deposits around the superficial vessels in the papillary dermis. Now, here is an important point to know. Even though there is a positive DIF, this is not an autoimmune disease. Why? Because the immunoglobulin here we see on the direct immunofluorescence are not true autoantibodies. They are just passively deposited, like due to the sun-induced damage to the vessel and dermal structures, allowing the serum protein like the IgG to get trapped. So unlike the disorders like bullous pemphigoid, there is no pathogenic immune response targeting a specific structure protein here. And also that is the reason we don't see much of inflammation. So under the subepidermal blistering disorders, we have talked about many of them. Here is a quick summary how to differentiate them based on some key factors. In your exam, if you see there are targeted antigen include BP180 or BP230, you should directly go to the BP. And if you see there is a salt split test, that means they are trying to differentiate the BP from EBA. And remember, B is blown is at the top, is at the roof. And EBA, E is the earth is at the floor. So we tell those two apart. And number 3, if you see the deposition is IgA, you should only have two differential diagnoses. One is the linear IgA, as the name implies it has a linear deposition. And if you see a granular IgA, that is dermatitis herpetiformis. At the level of pathology residency, I don't think you need to remember this bullous lupus in this category. Just remember those 4. Perfect. We have finished the part 1 of this lecture, which is intraepidermal and subepidermal blistering disorders. And now let's briefly talk about a little bit of the inherited disorder which may have intraepidermal separation. And the first disorder in this category is we call Darier's disease. So what is Darier's disease? This is an inherited acantholytic dermatosis caused by mutation in the ATP2A2 gene, which affects calcium signaling in keratinocyte. And histologically, we will see a focal acantholysis, usually in the lower epidermis, along with prominent dyskeratosis. You can see the dyskeratosis, and we give them some fancy names, including corons and grains. Corons are the dyskeratotic round keratinocytes found in the spinous layer, and the grains are smaller, flattened dyskeratotic cells found in the stratum corneum. A very helpful mnemonic for me is the DDD. Darius disease has 2 Ds, and it has 3 Ds. One is deep, because the separation is usually at the deep, and we will see abundant dyskeratosis. And the other one is a stretch. You see ATP 2A2 means there are double 2. That is how I remembered. And clinically, these lesions are usually greasy, warty papules, often on the chest, back, or neck. And if you do the direct immunofluorescence, it is negative. And next disorder is Hailey-Hailey disease. This is also an inherited disorder, but through a mutation, no longer ATP2A2, but ATP2C1. Unlike the Darius disease, here we see more extensive acantholysis at all levels of the epidermis, which Darius is more deep, giving rise to that classic dilapidated brick wall, which this is the very old Great Wall in China. Give you the dilapidated brick wall appearance histologically. And you might see some dyskeratosis, but it is less prominent than the Darius disease. Clinically, patients are usually present with painful erosions in intertriginous area, such as axilla or groin. And again, the direct immunofluorescence will be negative, because this is an inherited disorder instead of autoimmune blistering disease. A fun mnemonic here is I want to see Halley's Comet one day. So you will remember there is 2C and 1, okay? And here is a side-by-side comparison. Darius disease is a seborrheic area, Hailey-Hailey intertriginous area. Mutation 2A2, HH 2C1. Acantholysis with dyskeratosis in Darius and acantholysis with less dyskeratosis in HH. And is there mucosal involvement? Darius has, HH does not. Okay. And lastly, but also important disorder is Grover's disease. It is also called transient acantholytic dermatosis, typically affects older men and show up on the trunk as crusted itchy papules. So clinical presentation may say rule out eczema. Histologically, you get those small scattered foci of acantholysis, often with dyskeratosis. But it, unlike the inherited form we just talked about, Grover's disease is not generic, and it is not genetic, and tends to be more sporadic or environmentally triggered, like heat or sweating. So it is quite common during the summertime. You may also see spongiosis and eosinophils, and importantly, the direct immunofluorescence is negative. Of course, today there is no way I can finish all the inherited disorders. This slide I mainly used for your board prep purposes. I usually give the board prep lecture to 4th year resident, usually in May or June sometime. But this one you can just take a screenshot for your reference. But one thing I want you to know that in general, for AP and CP board exams, the skin-related inherited disorder, they are all autosomal dominant. So that is a dirty way to remember. So that finished up today's lecture, and thank you so much for attending this lecture. It is my great pleasure to involve in your residency education. And if you have any further questions, or if you have any suggestions or any question regarding Dermpath, please feel free to contact me. And this is my email address. And I wish you best of luck in today's working, and see you next month.